Okay. Welcome. Hi, everyone. Welcome to the third part in a webinar series from GIN North America around incorporating a health equity lens into clinical practice guidelines. So today we are really pleased to welcome two extremely knowledgeable speakers who are going to present a framework for incorporating health equity throughout the recommendation-making process. There is a part 4 of this equity series that's in the works, and please do keep your eyes open in the next week or so for more details on that webinar. We are looking to host that webinar on April 26th. So my name is Kate Carroll. I am a member of the GIN North America Steering Committee, and in my day-to-day, I am the Director of Clinical Guidelines and Population Health at the American College of Physicians. So I'm very happy to serve as your moderator today for this session. Next slide, please. So before we dive in, I would just first like to share some highlights about GIN North America. GIN North America is a regional community of the Guidelines International Network and has been since 2010. Fun fact that GIN North America was the first regional community of GIN. And the aim of GIN North America is to provide a network for North American guideline users, developers, and others to form partnerships, collaborate, and discuss regional guideline issues. So the membership of GIN North America consists of guideline developers, guideline adapters and implementers, in addition to systematic reviewers and researchers from Canada, Mexico, and the United States. So to accomplish our aims, we organize webinar series, regional events, virtual coffee chats, and other interesting opportunities where you can meet, share, and collaborate. So if you're not as familiar with GIN, really urge you to check out the website. And if you're not a member, please do consider joining GIN. It's a wonderful way to access resources and participate in a global community that's truly committed to trustworthy and accessible guidance for better health. For both new and existing members, please do make sure that you create an account on GIN Connect, which is the networking platform for GIN members. And this is the best way to stay on top of the latest offerings in the GIN community. I will drop a link in the chat for you for GIN Connect. A note that this webinar will be recorded and available on the GIN YouTube page. So a reminder that registration is also now open for the Global Evidence Summit, which is taking place in the beautiful and historic city of Prague from September 10th to 13th. This is the second Global Evidence Summit, and it's a really unique opportunity for colleagues across the globe to meet and exchange ideas about how to best produce, summarize, and disseminate evidence to inform policy and practice with our ultimate shared aim of improving lives. So early bird registration does close June 13th, and so we really encourage you to take a look at that and get registered. Just a few housekeeping reminders in that just another second reminder that this webinar is being recorded and it will be posted to GIN's YouTube page after. Please stay on mute to ensure a nice and easy listening experience for other attendees. We'd also ask you to keep your video off to manage the bandwidth for the webinar. We have built in time for questions and discussion after the presentations. So please do use the Q&A option to share your questions. You should see this next to the chat box in the Zoom control bar. Okay. And so, we can now get into the webinar. And today's webinar is aimed at an introductory framing level. So this is really Race and Racism in Clinical Guideline Development 101. Next slide, please. I'm very delighted to introduce you to our two speakers. We have Dr. Jennifer Lin, who's a board-certified practicing general internist in primary care with Northwest Permanente and the director of the Kaiser Permanente Evidence-Based Practice Center. She's also a professor in Kaiser Permanente School of Medicine. Her career interests have focused on evidence-based medicine and healthcare policy in primary and preventive care. She serves as the Evidence-Based Practice Center's principal investigator on the United States Preventive Services Task Force contracts for systematic reviews, methods work, and portfolio management to support the task force recommendation process. She's recognized by her peers as an expert in systematic review methodology, evidence-based medicine, and clinical prevention. Dr. Lynn has significant experience in conducting reviews on prevention in primary care, complex interventions, behavioral counseling, and many more topics. She has led and consulted on methods work centered around health equity, as well as evaluation of medical tests and applied evidence reviews for health systems, guideline groups, and other decision makers. Dr. Lynn also serves on the American College of Physicians Clinical Guidelines Committee and its Methods Subgroup, and she's a non-voting member on Kaiser Permanente's National Guidelines Committee. She obtained her medical degree at NYU School of Medicine. She completed both a residency and chief residency in internal medicine at NYU Bellevue Hospital, and she completed fellowships in evidence-based healthcare at Oxford University and in health services research at the Portland Veterans Administration Medical Center. Dr. Iris Mabry Hernandez is a medical officer for the United States Preventive Services Task Force program at the Agency for Healthcare Research and Quality. Her professional areas of interest include child health, prevention, and evidence-based medicine. She received a Bachelor of Science in Chemistry from Xavier University of Louisiana and a medical degree from the University of Tennessee Health Science Center. Dr. Mabry Hernandez is completed a pediatric residency at the University of Arkansas for medical sciences. She is a board certified pediatrician and completed a general pediatrics fellowship at Johns Hopkins University and a pediatric health services research fellowship at the University of Michigan. She received a Master of Public Health degree from Johns Hopkins Bloomberg School of Health. Next slide, please. For our disclosures of interest, Dr. Lynn has disclosed that she is principal investigator on ARC contracts for systematic reviews and technical assistance to support the United States Preventive Services Task Force. Dr. Mabry Hernandez has no relevant financial disclosures and notes that the views in this presentation are her own and do not necessarily represent the views of ARC. I disclose that my partner is employed by a personal injury law firm that sometimes works on medical malpractice cases that may cite or refer to clinical guidelines in support of their case. And with that, I am pleased to stop yakking and turn it over to Jen for her presentation.
Hi, can you hear me? Yeah, great.
Yeah.
Great. Thank you, Kate, for those kind words. And thank you to Kate, Dina, and Urato for inviting both Iris and I to speak with y'all today. So we're really pleased to be here. The outline of today's webinar is pretty simple. I'll be talking a little bit about the health equity framework that our group was lucky enough to develop for the task force. And then Iris will be giving you the updates from the task force around their efforts around health equity and anti-racism. And as Kate mentioned, we'll have time for Q&A. So this is a snapshot of the paper that we did in support of the task force. This was done in 2022 and 2023, and the full report link is listed there. And actually, the manuscript was just published earlier this week in JAMA Open for those who want a more succinct read. Essentially, this framework we developed was to incorporate health equity at all stages of the recommendation process, all the way from topic nomination down to the dissemination of recommendations. And I really just want to give a huge thanks to Beth Weber, Sarah Bean, and Corey Evans, my colleagues who keep me humble with their brilliance. So as a little bit of context, especially I think if you weren't able to attend the first of the webinars in this series, is This work that we're talking about today really is one in a suite of work that we have been lucky enough to do for the task force. The first work in this portfolio was released in 2021, and again, a snapshot of the paper here with a full link. A link to the full report below, was really kind of setting the context for addressing racism in preventative services. And then shortly thereafter, the task force prioritized developing a health equity framework to guide its pilot work in incorporating health equity in general, regarding all equity deserving populations, and also in specific, racial health equity in its recommendations. But the equity framework I'm going to be talking about today is more broadly focused on, again, all equity deserving populations. So just to level set, when I mention health equity for this paper and for this presentation, we are using the term to refer to the absence of meaningful differences in condition prevalence, morbidity, mortality from said condition, and differences in the receipt of clinical preventative services across populations due to disadvantage. I also want to introduce another term that may or may not be familiar to folks. This term was coined by Sir Michael Marmot a long time ago, which I think is particularly salient to how we might achieve health equity within healthcare. And this is proportionate universalism, which is basically defined as needing and resourcing and delivering universal services at a scale and intensity proportionate to the degree of need, which I really think is central to health equity rather than health equality. So just very briefly, I want to mention our methods and also give a nod to the GRADE guidance. We very much use the GRADE working group's guidance on health equity, did a crosswalk of their guidance to the existing task force procedures. And then we used a number of additional pieces of guidance that we had identified from our prior work, the Addressing Racism report, which I mentioned, as well as targeted searches. And if you're interested in those other pieces of guidance, it is cited in our report and our manuscript. And the GRADE guidance was enormously helpful, but did lack certain operational details in how to implement the guidance. So in addition to using our own methodologic expertise as an EPC and our fellow EPCs that support the task force, we also consulted with multiple guideline members, both current and past members, as well as the task force contractors and their partners involved at each phase of the process. And then this framework was reviewed, a draft of it was reviewed by the task force's federal and DNI partners. And what you see here is the aggregation of all of those parts. So this slide is really a 10,000-foot level view of what the framework looks like. And essentially our framework is organized by the phase of recommendation in the recommendation process, from, again, topic nomination, selection, prioritization, then to the work plan or protocol phase, to the evidence review, conduct of the evidence review, the evidence deliberation, then the development of the recommendation statement, and the dissemination and implementation of recommendations. So for each of these phases, we do mention what we think should happen, or at minimum be considered, as well as the rationale for why it should happen. And that's the actions column. And you'll see that there's a number of actions per phase of the recommendation. And then we also offer maybe a more pragmatic checklist of basically how one or the task force might go and implement these action items. And you can see the checklist items vary from, several checklist items to 30 or so checklist items per phase of the recommendation. And I do want to emphasize that that we put together this framework and checklist as an ideal, and we realize that a lot of these actions may require additional resources to operationalize. So this was really setting forth some guidance for our main consumer, the U.S. Preventive Service Task Force, but I'm hoping that each of you find it of value to your portfolios and your work as well. So in the interest of time, I'm not going to go over each action item and checklist item, but I am going to pull out one example from each phase of the recommendation just to illustrate what that looks like. So starting with the first phase of the recommendation process, topic nomination, selection, prioritization. One of our action items is really to explicitly consider health equity during the selection and prioritization process. And the checklist item really is using health equity as a criterion for this selection process. And you can see below, I have a quote from the task force procedure manual that illustrates the task force criterion that builds health equity into their criterion on public health importance. And they do have this parenthetical that says, including the potential for a task force recommendation to address racism and health inequities. In order to operationalize using health equity as a criterion, it's important to have health equity information delivered or in background documents that inform the topic prioritization and selection process. And in the task force, we basically use background documents to inform this process. And in those background documents, they now include information on social risk factors, for example, poverty, access to care, that intersect with race and or ethnicity or other population groupings like gender and sexual orientation or persons with disabilities. And also information on the prevalence and burden of disease across different populations, recommendations by others in these specific populations, and some detail on inequities and how preventative services are provided, accessed, or received. So it's building in this sort of evidence-based process early on in the recommendation process. So moving on to another example from the work plan phase, and I'm using the work plan and protocol phase somewhat synonymously. In the task force terminology, we refer to this sort of topic refinement phase as the work plan phase. Essentially, our guidance recommends that detailing health disparities really needs to start at this planning phase, and not just understanding the differences in condition, incidence, its risk factors, and its morbidity and mortality, but really understanding also the mechanisms that lead to these differences. And so this includes asking and answering what are the upstream determinants that lead to these disparities. Often, we're talking about structural and social determinants at this level. Understanding if there are differences in etiology and natural history that might lead to disparities. Understanding if there are potential factors that might mediate or moderate a clinical service's effectiveness or harms. And then also understanding what are the differences in access to and uptake of a given clinical preventive service. And because the task force focuses on preventative services, we also think it's important not just to understand differences in access and uptake of the preventive service, but also for the immediate downstream care, for example, screening and as well as follow-up for abnormal screening. And oftentimes, it is not just the uptake and access to a clinical service, but sort of the downstream care, differences in downstream care that lead to significant differences in morbidity and mortality. So at the review phase, if you remember, we had, I think, over like a dozen actions and 30 checklist items. I will say maybe in some ways it's this framework is a little bit biased in being heavy on the evidence review phase, and that's who it was developed by. But we think that this is a critical piece of getting the right information to decision makers. So this action really is focusing on detailing the findings by equity deserving populations in the summary of evidence or strength of evidence table that really allows the decision maker to make an assessment of the magnitude of benefit and harms in these populations. And it really is focusing on understanding what are the absolute effects in these populations. This is separate from, we actually have another action item that details using subgroup and interpreting subgroup analyses. I want to say that subgroup analyses, in my experience in the reviews that we've done, are generally deficient in informing benefits and harms in equity deserving populations for a number of reasons. So what we're advocating here for is really estimating absolute effects across different populations using formal or informal modeling. The task force calls these informal modeling exercises outcomes tables. And if you're interested in these outcomes tables, you can refer to the task force procedure manual for additional detail. But essentially, it's using and understanding what is the baseline risk of outcomes or across different populations and applying those relative effects that we see in the included studies that might be done in more narrow populations and applying them to sort of the baseline risk in different populations to get a better understanding what the magnitude of effect might be in these equity deserving populations. So this is just a very last minute mock outcomes table just to give maybe a somewhat more concrete example of what an outcomes table looked like. And essentially, it is an informal modeling process. It basically allows a simple snapshot of understanding the best benefits and harms for any given service. This example is from prostate cancer screening. And you can see the outcomes are listed on the left column. I have excerpted from the outcomes table in the task force's prior screening review for prostate cancer. The numbers or the projected numbers estimated from the ERSPIC trial that was primarily in men of European ancestry. So you get a sense of both the magnitude of benefits and harms in this population. And the idea is that you can estimate, again, through informal modeling in equity deserving populations, and in this case, in Black men. And it's really important when putting together these estimates, because they are in fact estimates, to be very clear about the underlying sources and assumptions being used for these projected estimates of benefits and absolute benefits and harms. So moving on to the deliberation phase, I think it's very important so to answer this question, and this is a grade question, what are the differences in benefits and harms by population due to differing baseline risk? This is the absolute differences that I've been talking about, as well as variable responsiveness or vulnerability. So these are the relative differences. So I think it's important to understand, are the differences because of absolute differences or relative differences? And I will say it is important that the default assumption be that any relative different that when in doubt, if we don't have subgroup analyses to really demonstrate relative differences in relative effects across equity deserving populations, the default assumption should be that these relative effects are generalizable to more diverse populations, unless there are really compelling reasons, most notably really differences in biology or physiology. There might be other reasons that you are seeing differences, for example, sociocultural influences or access to healthcare delivery. And these are generally not appropriate reasons to limit the applicability of findings, but they may be very critical to understand because they might require a guideline group to implement or to acknowledge implementation considerations when implementing a recommended service. So here's another example of a checklist item or checklist items from the deliberation phase. Again, that top question that you see there, that is very much a grade question, asking what is the potential impact of the recommendation on health equity? And I think that, it is important not only to answer the grade question, what is the potential impact, but implicit in that is to understand why it is, and then also what practice considerations do you as a guideline group need to articulate to ensure that inequities are reduced and new equities are not created. And I would say at a bare minimum that existing inequities are not perpetuated or exacerbated. And to get at these implementation considerations, it is important to address resource considerations, feasibility, especially if a service is fairly complex or not widely available or resource intensive. It is really important to understand the acceptability of the service across equity deserving populations. Again, especially if the service is invasive, has known suboptimal uptake, or there are multiple options for an effective clinical service. And then in our guidance, we also advocate that looking at evidence to increase ways of increasing the uptake or receipt of a given service is important as well. So moving on to actually crafting the recommendation statement. So this is really important to communicate considerations for, again, specific populations. And, we start with inclusive language. And I want to just make a point that language really matters. This is not kind of an academic semantics exercise. So using inclusive language is critical. And I think it's also really important to have consider offering text around the differential implementation of service, if that is needed, and especially if text really needs to be highlighted for sort of the equitable allocation and receipt of recommended services. If there are differential uptake of services across populations, we also suggest actually providing resources that might allow someone who's implementing these recommendations to improve the uptake of services in their context. One example from the task force is not necessarily providing it within the recommendation statement, but pointing to other groups, for example, the community guide at the CDC, who offer resources, evidence-based resources that may be effective. So either to provide that within the recommendations statement itself, or to refer to others that have those resources or guidance. And then if there are equity relevant evidence or clinical practice gaps, that those should be articulated by guideline groups. And Iris is going to speak a little bit more on a task force example about developing equity related evidence gaps. So for the dissemination and implementation of recommendations, I want to mention that our framework focuses more on the dissemination rather than the implementation. That is one of the areas that I think really does need to be developed, is sort of a checklist or guidance for the implementation of recommendations, but focusing on more the dissemination. This action item focuses on the communication to a broader audience. Our communications team that we work with really is advocating for both proactive and reactive messaging. That is, what are you going to say, meaning proactive communication, as well as how are you going to respond to certain questions? So that's the reactive messaging, but really to have those speaking points developed specific to health equity. It's also really important that media focus or dissemination efforts focus on groups that are representing or serving specific populations. It might not be sufficient just to do sort of a broad communication strategy. One of the most important feedback that we heard from the DNI, the dissemination and implementation partners for the task force, is that really focusing on developing actionable messages for those who are more on the ground. And without providing actionable messages, it is, again, just an academic exercise. And then, in order to do that, it does require, in order to do, this sort of effective communication and dissemination strategy, it does require, or at least we offer guidance on leveraging existing key partners, whether they be, again, groups serving specific populations and or actual community partners as well. So before handing it over to Iris, I just wanted to make just a few concluding remarks. And the first is that we recognize that this health equity framework is really just a starting point. So it by no means is comprehensive, and it by no means is the last framework you're going to see in general or for the task force. We do think it provides an architecture of what the task force and we hope other groups could do, again, with the caveat in a world where there are no resource limitations. So because we live in the real world, I think what gets adopted into a guideline group and by the task force really depends on a lot of other practical and external circumstances. But we believe that, rather than adopting this framework whole cloth, that change and effective change can happen incrementally, and meaningful change can happen even if parts are rather than the entirety are adopted by the task force or a guideline group. And we think that by doing this, it does lead to a more sort of transparent and intentional approach to addressing health equity. So I encourage, if folks are interested, this was a very, very cursory introduction to the framework. I'd be happy to answer questions at the end or correspond. Feel free to reach out to me by email. Very much a passion project, and happy to talk to folks about it at your convenience. So I'm going to turn it over to Iris at this point.
Thanks, Jen. Can you all hear me?
Yeah.
Great. All right, thank you. Next slide. So I'm going to highlight just a very high-level overview of some of the task force's initiatives to address racism, health equity, and preventive service recommendations. And so first, I'd like to highlight that the task force is committed to helping reverse the negative impact of systemic racism on health. And they previously looked at race and how to consider it appropriately throughout their recommendation development process. But a few years ago, they decided to intentionally move from a focus on race to focus on racism. And this is in part due to the fact that they recognize that health inequities are due to social, economic, and structural factors such as structural racism. And so they've been working to develop strategies to help mitigate the influence of systemic racism in their recommendations. Next slide. And so I want to highlight some action steps that the task force developed to address racism. This was published in their JAMA Viewpoint, which Jim mentioned earlier in the presentation, and it serves as a roadmap for the task force. And so, number one, to consider race as a social and not a biological construct. Number two, to promote racial and ethnic diversity and membership and leadership, and foster a culture of inclusivity. Number three, the task force commissioned a report to understand how systemic racism undermines the benefits of evidence-based medical preventive services. Again, that was mentioned earlier in the presentation. Number four, for the task force to iteratively update its methods to overcome health inequities experienced by populations affected by systemic racism. Number five, to communicate gaps created by systemic racism in all dissemination efforts. And number six, to collaborate with his partners and experts to reduce the influence of systemic racism on health. Next slide. And so in order to address this important issue, the task force created a work group specifically to address race, racism, and health equity in clinical preventive services. And as mentioned before, they commissioned a report, which is completed in June 2021. And they outlined their critical first steps for them to undergo in order to create change in how they recognize and address systemic racism around clinical preventive services. And so I just mentioned the action steps. Next slide. And so this is also from their viewpoint. It's kind of gets to specific details of the roadmap, and I'll just highlight a few issues. So this reflects their components and some proposed actions which they've undergone, and Jen's mentioned some of them. So for example, with the overall approach, the idea, of course, moving beyond race as a proxy for racism and directly addressing its impact on clinical services, and developing, integrating, and refining a health equity framework into their methods, which obviously they've been doing. With regards to the task force expertise, again, promoting sustained diversity and task force membership through active recruitment, increasing diversity from underrepresented groups across task force leadership roles, and building expertise in health disparities for clinical preventive services. With regard to informing evidence reviews, again, identifying systemic racism as a causal factor for variations in prevalence and outcomes, potentially identifying or including contextual questions on evidence-based interventions to reduce inequities caused by systemic racism within a specific recommendation statement. Next slide. With regards to interpreting the evidence, proposed task force reaction was to consider the use of applicability, extrapolation, modeling, individual patient data, meta-analysis, and other methods to address evidence gaps, and identifying the types of outcomes needed to address racism. And then when it comes with regards to communicating evidence gaps, the proposed task force actions included routinely highlighting evidence gaps related to race and racism, calling for additional research, seeking partnership with the Community Preventive Services Task Force and other guideline-making bodies, and working on their communications approach. Again, you heard some details about these actions presented by Jennifer. Next slide. So I'm going to just highlight some specific additional actions that the task force has been doing. So as mentioned before, the health equity framework that Jennifer described, there's a full methods report that is posted on the website, and the manuscript was just published this Monday. And the task force is planning on updating their 2021 article, Actions to Transform the U.S. Preventive Services Task Force Methods to Mitigate Systemic Racism in Clinical Preventive Services. So this article will talk about, reflect on what's happened so far in this process and possible next steps. Next slide. Another example, specific example of what the task force has done is to include text added to their preamble, which comes before their recommendation statements and in draft research plans to highlight the task force's approach to health equity in the research plan. In the research plan, there's a section entitled Approaching the Approach to Assessing Health Equity and Variation Across Populations. So again, trying to be intentional in demonstrating their interest in addressing health equity. Task force has also, as mentioned earlier, incorporated contextual questions in their analytic frameworks with a pilot of 10 topics to address health inequities across populations, drivers of health inequities, and interventions to reduce health inequities. And they're currently looking at these pilots and reflecting on the impact that these pilots are having on their recommendation statements. Next slide. The task force has also begun to discuss racial bias and algorithms and risk assessment tools used in preventive services, and recently posted a methods report on assessing algorithmic bias and fairness in clinical prediction models for preventive services on the task force website, and are actively considering how to incorporate these findings in their process. The task force, in an effort to be inclusive, continue to welcome new D&I partner organizations and their representatives, such as members from the National Medical Association and the Hispanic National Medical Association. And as mentioned previously, they are developing an inclusive language guide. It's an internal document, but to inform communications. Next slide. Another effort that the task force is undergoing is addressing research gaps. And to fulfill its mission to improve health by making evidence-based recommendations for preventive services, they routinely highlight the most critical evidence gaps. And these gaps are presented in the research needs and gaps section in each recommendation statement, and also are summarized in the task force annual report to Congress. And so recently, the National Academies of Sciences, Engineering, and Medicine issued a report in taxonomy to assist the task force in classifying and prioritizing evidence gaps. And the task force is applying elements of this taxonomy to its process of identifying evidence gaps, particularly those that reflect health inequities and racism. And the idea of this, or the goal, is to better inform researchers on studies to address evidence gaps. And there's a link to the full report available on the JAMA network. Next slide. So oh, go ahead, sorry.
Oh no, Iris, do you want to do this slide or do you want me to? It's up to you.
Oh, yeah, I was going to read through it, sorry. What you can do now, examine your own processes to determine what processes and methods are in place to address equity in your guidelines. What topics are in your portfolio would benefit from explicitly addressing health equity? What processes and methods might be easy to adopt that would help address equity? And can you choose items to implement at each phase of your process? Be intentional regarding diversity, whether it's racial, ethnic, gender, sexual orientation, geography, et cetera, in your membership and leadership. And strongly consider consider equity consciousness training for guideline panel members and staff. And I will add that currently the task force is just beginning a process of examining equity consciousness and implicit bias and how it can impact recommendation statements. Thanks. Next slide.
Great. So I just wanted to end by plugging an upcoming summit that's going to be focused specifically on racial and ethnic health equity in both systematic reviews that support healthcare decision-making, as well as evidence-based healthcare guidelines and guideline-like processes. And this is going to be in June of this year. It's co-sponsored by the Robert Wood Johnson Foundation, U.S. Cochrane, and HRQ's EPC program. And you can see from the meeting aims here, it's very much going to be a working meeting to identify the priority actions that need to happen in order to transform, our sort of evidence ecosystem to support addressing racial health equity in guidelines, and as well as identifying metrics or measures of success on and how we know that we're actually doing what we said we would do. And it will be a collection of folks, research funders, as well as evidence reviewers, guideline makers, health technology assessment groups, as well as other evidence-based recommendation groups, dissemination implementation partners, quality metric folks. So we hope that this summit will be the start of kind of a larger collaboration, whether it be formal or informal. So hopefully we'll be able to feedback some learnings to this group or interested folks after that meeting. So now, Kate, I'm going to turn it back over to you. I think we left ample time for questions if people were interested.
Great, thank you. And Jen, your audio was good for a while, but it just started to get a little lower. So yeah, thank you.
Okay.
Perfect. Wonderful. Well, thank you both so much for walking through that. A reminder to attendees that you can use the Q&A to drop questions. If you're having any trouble locating the Q&A, then the chat is fine. You can just drop a question in the chat as well. So to get started, I certainly have some questions, and I really appreciated those last couple of slides, what you can do now in particular. And so I think just expanding on that a bit, I would love to hear your thoughts a bit more on if the question is, where should I start? And perhaps speaking a bit to how we would approach this operation to operationalize it if we really feel like we're starting out. Is this something that we can approach incrementally? Would it be something that we're better off building up the resources to take on a much more thorough, comprehensive strategic approach? Any tips or thoughts on that?
Thanks, Kate. I'll start, and then Iris, I think maybe from a practical standpoint from the task force, since the task force is, looking to implement some of this, maybe can speak to some of the challenges. But so let me just say, from a personal perspective, I will acknowledge a few things. One is I've been doing applied reviews for guideline groups for many years. And so I'm very aware that there are resources, time and resource constraints in doing this work. And in order to do this work, it has to be practical. It has to be sustainable. I will also acknowledge my bias that I think that this is incredibly important to do in terms of building in health equity intentionally throughout the process. So I would say there is nobody who can probably adopt the entire framework as it's set out, and that's not the intention. And if one waits for enough resources to do it, it's never going to happen. And I would also put out there that I think there is some urgency to do this, and there is some larger momentum in that of this importance, and to build on that sort of societal momentum in order to do this is really important. So I would say the time is now, or the time was yesterday. And it's important to not feel like you have to do all of it, because then it's never going to happen. And you need to be able to implement things that are sustainable. And so I would also advocate, if you are going to choose items within this framework, or, you know, starting with the grade framework or any of the other papers that we cite. I think it's important to choose things that feel feasible and that you have leadership and membership agreement, because it's only going to be successful if everybody's on board. I would also really advocate, which is why that extra bullet is put in there, you know, if you can think, or if you have the generosity to implement more than one thing, can you choose things from different phases of the process? My personal bias would be to choose things at the earlier phases, because unless you build it in intentionally at the beginning of the process, as early as topic prioritization and topic development, you know, it's not going to be as effective or lasting change. And then I will also say that, you know, there is an opportunity to, not that I want people to be non-committal to this, but there is an opportunity to pilot it, or talk with other folks who have piloted aspects of this. You know, some of what's in our framework is not new. There are examples or exemplars of others who have done it. And so to understand where the challenges in their processes in implementing it have been, where perhaps the most return on value, not to break this down into sort of like a you know, a cost effectiveness approach, but, you know, where they thought the most bang for the buck was, and starting there. So again, I think there's lots of ways to do this. There's lots of ways to, even before you pilot it, to understand what's worked well and not for others. And then I think when you look at the framework and you look at the checklist items, you'll see that there are some stuff that is happening within your portfolio already, but maybe is done sort of as an as needed or sort of post hoc kind of fashion. So to be more intentional about it and consider it, even if you're not going to implement it, to consider it for your equity relevant topics, I think is important. So it might be that you're not, you know, it's not like you're introducing something brand new, but you're doing something more consistently or intentionally.
Iris, did you have anything that you wanted to add?
I actually lost connection, so I just jumped in, so I'm not sure what was. I'm sorry. That's why I'm not.
Sorry about that. It seems like there are weather-related connection issues across the country today. We're getting a lot of that message, so I'm glad you're back with us, Iris. We've got a question from an attendee. Great presentation. Thank you. Is ageism one of the equity topics to be addressed? Would the task force consider assessing the evidence for recommending the upper age limit for HIV testing, for example, older than 65 years?
Yeah. Great. Yeah, question. Yes. So I think there are, so I'll say a couple things. One is absolutely, yes, age, older aged adults, is absolutely in many cases what we would consider an equity deserving population, from many different aspects. Obviously it depends on the content. And although the framework was done because of the historical context with sort of a more considered lens on race and ethnicity, it is broadly applicable to sort of all equity deserving populations. So we you know, and we recognize this as a first draft or a first iteration. So, you know, maybe there will need to be checklist items added or refined to be more inclusive of, you know, for example, older adult or other equity deserving populations by age. I will defer the consideration of age in actual specific topics, you know, maybe to Iris, but I know from working for the task force for many years that they really are interested in, you know, all individuals across the age span. I think some of it has to do with limitations in the existing evidence base and who it applies to an age. So in this framework, we do really talk about this idea of when and how, when it is appropriate to extrapolate, because I think if we do this sort of evidence purist, narrow look at like who's included in populations and, applying our recommendations to those populations only, we are missing, one, I don't think we extrapolate all the time. And so for us to be more considerate about extrapolation, and again, the default assumption really being you can extrapolate unless there are good reasons not to. And granted, that's somewhat subjective, but, I think that that's really important for us as a community who believes in the evidence, but not to be hamstrung by the evidence in an imperfect world, because we are not going to adequately address equity in a timely fashion if we wait for the best evidence, the evidence that we think we want. So I think there is an opportunity for growth there, but I'm not in charge of anything. So, I think that's to the guideline groups to make decisions on, again, for example, extending age, extending to, persons with disabilities is often an neglected group who, rural populations, populations that are resourced in a different manner altogether. These are often populations that are kind of implicitly excluded from guidelines. And so I think that this framework at least offers some considerations on how we might begin to extrapolate and more consistently think more broadly, not just to older adults, but I think that's a great example.
Yes, this is Iris. I was just to piggyback what Jen says. I mean, the task force acknowledges and does try to incorporate, based on where the evidence is about different age groups, and they do have recommendations that stratify or include older groups and so forth, based on the evidence in that particular topic. And of course, that, as mentioned, that is an area to continue to move forward on, or to continue to progress in.
Great, thank you. I've got another question here. Again, thank you for this overview. It seems these messages and recommendations need to be adopted by journals. If journals don't require reporting on equity-related data, then guideline developers are limited by the evidence. Any reactions to that?
I 100% agree. I think I'm not expert in this area, but my understanding is that there has been advancements by journals and editors on, I wouldn't say mandating, but best practices, and including the data that we need, that we include in reviews and guidelines. So my understanding is that is happening, and my understanding is that at a systematic review level, there are efforts to have those sort of reporting guidelines at the review level as well. So I think absolutely things don't happen unless there are requirements or incentives for them to happen. So I 100% agree that's important.
I agree also that that's important. There are some journals that have explicitly, committed to moving forward in health equity, for example, JAMA. So I think taking advantage of those, opportunities is important. But there's a lot more that needs to be done, obviously.
Great, thank you, Iris. Jen, sorry, I think I can hear you all, but I think again the mic might be moving away from your mouth and the volume's coming in and out a bit. Great. So something I want to kind of go back to an kind of an earlier comment that you were making, Jen, about so it seems to me that there, in reading through the paper recently, the framework from the task force, that there are a lot of concepts that are in there that we're already doing, that we're already looking at. You know, and I had a colleague note to me that, you know, there's a set of contextual questions presented in the framework, and that the contextual questions, right, these aren't explicitly using the term equity, but they're talking about things like disparities, patient values and preferences, feasibility, implementation. And so I was wondering if you think that this perhaps speaks to a way in which we kind of have to approach equity with a slightly different mindset than what we're used to as guideline developers and reviewers. And I think by that, I mean, you know, ACP does use grades, evidence to decision framework. So we've got our organized boxes, you know, we're reporting a judgment in this row about clinical benefits and harms, in this row about values and preferences, this row about resource considerations, and so on. So of course we do weave all these things together when making the recommendation. But I think what I've heard from you is that with equity, we're really weaving it in and integrating in every step of the process. And so I think my question then is, do you think that we kind of have an existing frame of reference for this, or do we need to prepare ourselves to approach this a little bit differently in terms of how we normally kind of tackle a question or an issue than just guideline development?
Yeah. So I think I figured out the mic thing. It's every time I take a drink of water, I move it and then I don't move it back. But anyway, sorry about that. So I think the answer to your question, Kate, is both. I think there is an existing framework that we can think about it, and there is a need to do other things beyond that existing framework as well. I will say the grade ETD framework is great. And I like the fact that there is an explicit health equity domain, but I also think it's important to weave in that health equity lens to all the domains. And so my fear is that by having that health equity domain separate, which is, I'm sure, not the intention of grade, but that it's like, oh, we can address it by answering this question. And when I talk to some folks, you know, in our resource constrained manners, it's just like, I'm like, how do you answer that question? And the answers are quite variable in the methods and the robustness to answering that, from it's a thought exercise to, you know, if we have time. So I think one of the things that this framework advocates for is layering in intentionally this health equity lens at every single phase of what we do. And so when you think of resources and feasibility, you know, for example, you know, it is looking at it through an equity lens. You know, and maybe this is what, in fact, the grade folks were thinking. And I think Vivian's on this, so if there's a lot of collective expertise on this call, so I don't think I need to be answering all these questions if folks want to chime in. But I also think, you know, there are a couple instances in this framework that I think require us to do things maybe a little bit differently. One thing is developing topics that are uniquely equity centric. I think another thing is maybe pushing guideline folks, and I'm speaking on behalf of the framework and not the task force. As an EPC, I think one thing is pushing guideline folks to not just articulate sort of the evidence gaps, but really focusing on what are the practice gaps and what are the underlying policies that might need to happen in order to address these practice gaps. And that is something I think that is not as comfortable to healthcare guidelines, and sitting on a healthcare guideline, Kate, with you all, I mean, I think sometimes we think of this as not within our purview, this is, but I think one of the major drivers of health inequities are, in fact, these upstream determinants, not just the implementation. The implementation, I feel like healthcare guidelines feel like, okay, that's a little bit more in our wheelhouse. We can put together implementation considerations, and that's great. And some have been doing it already. But, I would challenge folks to think about, if you have the bandwidth, to think about how your group's role might be able to affect some of these upstream determinants that are in many ways the root causes and the largest drivers, within, so I'll just throw it out there. I do think there are things that can be thought of differently outside of our traditional box. But if you were to start somewhere, just start thinking about how to layer it into the existing processes, if that seems too daunting or you simply don't agree with that sort of statement.
Thanks for that. Iris, I don't know if you had anything you wanted to add to this.
No, I didn't. Thanks.
Okay. So it would another question that great to hear that task force is developing a guide on inclusive language. In the meantime, what are there other good existing sources for guidance on inclusive language that we can reference?
Well, I believe that, for example, there's some language or resources on the CDC's website. It could certainly, I know our communications team is very good about, they've been using resources in this process. And so we could, email me and connect. We could connect offline and I can, share that. I think APA perhaps, there might be others in the audience that are aware, but there are, other bodies that are addressing this.
Great, thanks. And we have in the chat a confirmation that the American Psychological Association does have an inclusive language guide.
Oh, great, thanks.
Jen, you were coming off mute, was that?
Yeah, I was going to say there's a lot of people who have been very intentional about inclusive language, and thanks, Raquel, for chiming in. That's a great starting point, APA. So there are a number of published, a number of journals have also published that as well. I know JAMA has come out with sort of preferred language. I just want to be cautious. I think striving towards inclusive language is really critical, and there are a lot of good starting points, but it evolves, and so there is no, especially when there's a lot of areas where, I don't think you're going to get full consensus on what is the preferred term. So steering away from sort of like preferred terminology to inclusive, and just recognizing that, there is the preferred is going to change over time. And like I said, from what we've seen, there's some, there are some areas where you're never going to get full agreement, but there's some great starting points.
Thank you. So again, on the slide, right, what you can do now, we have be intentional regarding diversity and membership and leadership. So do you have thoughts or advice on if groups are finding that their standard routes or pathways to membership are really not getting to a level of diversity, or are there strategies or are there resources or organizations that these groups could reach out to if you're just having trouble identifying panel members that you feel like are going to bring a diverse perspective?
Yes, well, I think one of the first things that you have to do is, first be intentional. A lot of times people, and not necessarily on purpose, tend to, associate or stay within their own networks and groups, right? And so they're unaware of other people who are going to be, just as qualified, because it's not top of mind or they're not in that social circle. So I think that one thing that's important, so for example, with the task force, as they've been engaging with new D&I partners, for example, that opens the possibility of meeting other possible members or who would fit the criteria for the task force, but they're in a different, or maybe I won't say non-traditional, but a group that maybe they had wasn't on their radar, for example. There are a lot, I can speak, like, for example, with in medicine, we have SGIM for internal medicine, PAS for pediatrics or what have you. And within those organizations, you often have, obviously, clinicians of color who are within those organizations are very active. Sometimes they have their own SIGs, their own SIGs, and so being intentional in connecting with people within your own group, if there are affinity groups or so forth. I guess in this example, it'd be with guideline groups. I don't know if that exists, if there are affinity groups within your larger guideline groups. But those are a couple of things. The other thing is, the pipeline issue. And, are there ways to expose, in this case, guideline development to up and coming medical students, residents, fellows who happen to be of color. Again, sometimes it's just that people are not aware of different career choices, but once they're aware, then they follow suit and become a part of that particular field. So that would be one thing, is what can people do to be inclusive or increase that pipeline as you think about the future. Those are just a couple of thoughts that I have.
Thanks for that, Iris. Okay. Let's see. Yeah, and just so everyone's aware, in the chat, Raquel did drop a link to the APA inclusive language guidance. And then, thank you, Vivian, for a response in the chat. I don't know if you wanted to come off mic to follow up on anything. Feel free to pop in if you did. So it was, let's see, it was also really nice to hear about the effort from the task force, right, around communicating research gaps. I think that this is, Jen, you talked about kind of thinking about like resources and yield and bang for buck, and that's, in the reality, is how we have to think about how we're doing this work, because we are working in resource constrained scenarios. But I think that, that the desire to have more evidence on this is strong. And do either of you have thoughts, or are you aware of existing collaborations or groups on how, or just ways in which we as more of a community can work together to communicate evidence gaps in a more unified front, right? Or really put the pressure on researchers and funders to provide us with more evidence around these areas, right? Any thoughts on that? If there are ways that we can really work together on sharing information of what we're finding and what we're not finding.
Go ahead,
Iris. I was going to speak to at least specifically with the task force. They actually have a relationship with, NIH the Office of Disease Promotion. And so it's an intentional collaboration where, particularly with I statements, but evidence gaps from the I statements and from other recommendations are shared with various the various institutes within NIH to encourage research, RFAs and so forth that NIH could ideally share with investigators. And so that's been going on for some time. And then also, and this is more sort of a report to Congress, but there is a kind of a snapshot of some evidence research gaps that are highlighted across various topics. And this is done annually. There's a different theme every year, but again, a different way of disseminating research needs. But as I was saying, the task force actually does extend itself to NIH to have those conversations.
Yeah, I mean, I think the task force is fortunate in the fact that they have sort of these developed relationships with research funders, and have a report to Congress that can highlight evidence gaps. And the development of, I don't mean to be a Debbie Downer, but the development of evidence, even in those processes, it's a long road. And I commented earlier on sort of the urgency to be able to implement. So I would say developing relationships with learning health systems is also another way of conducting maybe pragmatic research, real-time research that might address some of the gaps. Depending on, so I think I think this issue of linking evidence synthesis to evidence generation, we've been talking about this as a community for a while, and I think that it is a necessary thing to happen, and I think some people have made some good efforts in this area, but for some reason it's just not as robust as it should be. I think guidelines should definitely be part of that, linking evidence to synthesis to evidence generation, because a lot of times the guideline groups honestly have a larger voice than the reviewers themselves. They have a platform, and a pragmatic platform, because you're guiding clinical care. So I think developing those relationships between research funders, non-traditional research funders, learning health systems is really important. And then there are some instances, I'll just throw it out there, for which it's important to develop evidence, but maybe one doesn't have to wait to implement something, even if the evidence is not ideal. And so I throw out there that to think about what is happening in the real world in clinical context. So for example, if the default of inaction is in fact harm and is in fact generating and perpetuating health disparities, then what does your evidence threshold have to be when the default practice is harm? Maybe we should be taking a patient safety approach, evidence approach. Again, I'm throwing it out there as just sort of food for thought, because I think this is my job. I think doing evidence reviews, including good quality evidence, having good quality evidence to synthesize, that's essential. I mean, it's really key. But I also think that it's important for us as a community to think about when we need that really high bar, when that high bar is in fact hindering our progress and actually negatively affecting large populations, and so, I just want to throw that out there for consideration as well.
I appreciate that. I love that I love you. Thank you for throwing that out there. It's a very good food for thought, I think. Really interesting thoughts around this. Okay, great. So I did pop just some links to the task force publications in the chat. And then I also and the ARC report as well. And then I'm also going to pop a link in the chat to the GIN YouTube page. Some folks were asking about accessing the recording, and so once it's available, it'll be posted here. And if you are on GIN Connect, I believe you'll get a little notification as well. So great. So we've just got a few minutes left. It looks like we've run through our questions. So I think I'll just, turn to Jen and Iris and see if you have any last minute closing thoughts. But beyond that, I just wanted to thank you so much for taking the time to do this today, to disseminate this really important work. I think that these are all just, we're all really, this is such an important topic, and we're all thinking about it and trying to figure it out. And so these opportunities to work together and talk through it together are really, really important. So any just final closing thoughts?
This is Cyrus. I have one thought, and that's, the idea of, when addressing this issue of health equity, there's so many, as has been discussed, issues, and it's a large task. I think that one thing that's important when thinking about this, and people are very dedicated to it, and so forth, is kind of what is or being grounded personally with the issue of equity and implicit bias. And we all have our biases and so forth. That's just human nature. But I think it helps to think about how to maximize what you're doing professionally by reflecting personally, whether it's through training or personal self-work, but to really get at issues or to understand issues of equity. Because these things obviously can impact how people practice and how they move in the world. And so I think if there are opportunities for organizations, obviously to do this, but also individuals to consider that.
Yeah, and I think thanks, Iris. I think my closing thought is first of all, thank you very much for having us. I really appreciate the opportunity to share. I really appreciate folks showing up and listening and taking time out of your busy schedule. So thank you, thank you, thank you. I put my email in the chat. I think that these webinars are great, but they are the start of conversations. And so please, sincerely, if you have questions, want to collaborate, if I can, anything, just feel free to reach out and contact, and, keep up the good work. That's it.
Great. Thank you again, Jen and Iris, and thank you all. And both Jen and Iris were kind enough to put their emails in the chat if you would like to grab those for some follow-up. But thank you all. Yeah, I would echo what Jen said. Thank you for taking the time out of, I know we're all super busy, and hopefully you found this to be a valuable use of your time. So thank you, everybody. Have a great weekend.